einem unserer wo wir auch den Korpass installiert haben. Wir sind hier normalerweise eingesetzt mit ca. 2 bis 3 Pflegekräften, also Assistenzpersonal und einem Arzt, der die Intervention durchführt. Der Arzt sitzt dann nach dem Positionieren des Katheters hier an dem an der Bedienkonsole, an dem Steuerpult. Und wir können jetzt einmal reingehen und uns das System im Untersuchungsraum ansehen. Ich werde jetzt den Roboter aufbauen und die Kassette hier einlegen. Erstmal das zur Seite. Das Display am Roboter zeigt mir jeden Schritt, den ich hier tun soll. Das ist also sehr simpel. So, wir haben hier den Coronardraht schon vorbereitet. Der wird jetzt hier in den Y-Connector eingelegt. So, jetzt ist der Roboter bereit, dass der Doktor den Draht von außen vorbringen kann. Ich kann mich jetzt in die Ecke stellen und bin auch aus dem Strahlenbereich ein wenig weg. An dem System sind derzeit 2 Pflegekräfte geschult und 2 Ärzte, die das System bedienen.
Hello, my name is Dr. Christian Tesche. I'm one of the senior cardiologists in interventional cardiology at the St. Johannes Hospital in Dortmund, and it's my pleasure to introduce you to our Corindus GRX robotic PCI system today. The workstation consists of a nice user interface, which is controlled by either joysticks or like a touchscreen, where you can perform your procedures by using either the joysticks to guide the devices like balloons or stents, the guide wire, and of course your guiding catheter. For the procedure itself, you have several features that can be applied. Starting from left to right, you have your device where you can put in and control like your stent when it is placed in the correct location all over the stenosis. In the middle of the workstation, you have the guide wire, and this technique enables several features where you can use like several different techniques for spinning, wiggle, or run through with the guide wire to cross your lesion, and next one to place your stent balloon. On the right hand side, you have the guiding catheter, which is normally placed before you start your procedure in the cath lab by one of the attendings. The ARTIS iconoangiography system consists of several parts: the C-arm, the detector unit, the huge display, then the cath lab table itself with the control panel. So the most important key feature is the flexibility with this foot area that allows for the ceiling-like procedure performance. Our large display allows for high sufficient image quality and is a keystone for guidance of our procedures.
When we started the robotic program here in Dortmund, we started with a rather small team. So I think it's important to first get some people of the personnel familiar with the system, and then increase the number of physicians and technicians to work with the system. So the robotic family started with 4 people, and now we are growing slowly, and in the meanwhile, 8 to 10 people are familiar with the system and are really keen to work with the system, and would like to have the opportunity to learn on how to really work best with the Corona system. There are a number of clear benefits together with the robotic system. So first, for the patient, I think it's a gain in accuracy. You can really place the stents exactly where you want to place the stents. This may be even more important in long lesions where you have to place several stents. It may be important in really sizing which kind of stent is the right stent. And it may help you in complex lesions with wiring the vessel and bring things forward in a safe way. It then may have a benefit for the personnel, because the radiation dose can be decreased significantly for the physician as well as for the technician, because you have to step back. The physician is probably in another room. The setup here in Dortmund is that we are sitting just outside the cath lab, so there is no radiation at all. And therefore, especially in high volume centers, it might be of great advantage to really reduce the radiation for the physician. Daily routine during robotic PCI is somehow different from the normal workflow in the cath lab. So we are only dealing with planned PCIs, so it's a more relaxed working compared with the myocardial infarction issue in other cath labs. I pointed out all patients have planned PCI, so we already know what we are talking about. We already can do our plans right before, and we are looking for patients with not the simplest coronary lesions, but on the other way, it should be not too complex. So I'm convinced that we should not go for trifurcation lesions with a 3 wires. So what we can easily treat is long lesions, and here comes the advantage of the system, because we can stent in a very exact manner, and what we can treat is bifurcation, 2-wire technique. All these lesions can easily be planned for robotic PCI. When we are talking about cases which will benefit most from robotic PCI, I have especially cases in mind where we need several stents, because it's then very important to exactly place the stents with not a lot of overlap, no gap. That's even more important. And where it might be important to measure the exact length of the stent, which is eventually needed. All these issues are nicely addressed with a robotic system, and therefore these patients probably benefit most from such a procedure. My favorite part when working with a robotic system is to sit very relaxed in the chair outside and let everybody other work, especially the roboter.
A very nice explanation of what the setup of the cath lab with the robotic PCI. I have 2 questions from the chat, maybe for you. The first one from Dr. Risanen is about the staff organization. Do you need some extra nurse when you do robotic?
Briefly, I think it's a typical case in which robotic systems might be superior over manual PCI. However, let's see. Well, this is a case of a middle-aged lady with an severe stenosis, which is more than calcified. Also, the distal left main seems to be affected, and the iris could confirm that there was a kind of a napping in the osteocirc, which is shown in the middle panel here. And looking at the reference vessel diameter in the left main, so there was RVD right about 4.5 over 5 millimeter, so that we decided to go for lesion preparation with lithotripsy, supported by our robotic system. So I just want to briefly introduce to the robotic system. This is the console, which is in the control room. You can steer and also manipulate the C-arm of your angio. You have the foot panel also to apply the radiation, which is showing here. And of course, you have some monitors. One of is the live monitor as well as the hemodynamics, and you have some view control to the cath lab just to communicate with your team. And this is the setup of the robotic system. And so we could start directly with the case here, and was it shown here? So this was just prepared, and we had selected an EBU 4.0, and here you can see the wiring with the robotic system. You can control the robotic guide wire with the middle knob here, which is shown here. The green knob is to guide your guiding catheter, and the left knob, you can see here how easy you can steer and navigate your wire down to the vessel, and this was completely controlled only by the robotic system. If we go a little bit forward for the sake of time, you also may appreciate the fact that we had introduced and advanced the second wire in the LED. Just regarding the guide wire positioning, that we have new software available, and I just want to focus in this short talk about the rotate and retract, the wiggle and the spin software, which has been introduced. What is rotate and retract? It's ROR, designed for the wire navigation, which automatically rotates the wire when the joystick is retracted, thereby retracting the wire tip, which is nicely shown here. So there was the false direction, and with the ROR, the rotation, which means 220 degree, could avoid the navigation in the wrong vessel. So this is a nice clinical example where rotate or retract is used. There was the false vessel navigated with retract. There was the rotation by 220 degrees, and automatically we navigate into the right LAD. The other and second software support is the spin, which is designed for lesion crossing. What does it mean? This means the full clockwise and counterclockwise rotation of the guide wire while advancing. This facilitates your lesion crossing. Here was in the silicon model, there was a lesion prepared, and you see how nicely the wire goes down to the lesion. Finally, we have the wiggle, which was navigation mode designed for wire navigation. That means that you have a combination of the oscillation of the wire while advancing, and simultaneously you have the rotate and retract when the joystick is retracted, and thereby you can redirect the wire tip very precisely. This shows an example of this new wiggle navigation software. You can appreciate how nicely the wire is going that direction you have before decided, and this was very smoothly, and I think it demonstrates the support of the software navigation. This is a clinical example, and with these new wiggling support for guide wire positioning, you can significantly reduce the wire time, which is demonstrated in this nice example. You can see how easy the wire is going down to the circ vessel. But back to our case. we decided to go for lithotripsy, which is also possible to perform with the robotic support. This was the balloon of the shockwave 4.0 millimeter over 12, which shows a nice expansion. Remember this napkin calcification. After that, we decided for a 3.5 over 28 millimeter drug-eluting, and you can see that there was some problems, quite difficult to position the stent. However, with the possibility to guide the steering, to steer the guide catheter, which is the green knob, and simultaneously to advance your stent, we finally reached the position which was directly in the ostium of the left main, and thereby, of course, be very precise, and we could use the millimeter steps to be very precise in this case. So just to summarize a little bit, you can see we want to advance. I have used the millimeter steps to be precise. This is now the implantation of the drug-eluting stent. And if you go a little bit forward, we will see that we had to use the final kiss, and after that the final pot. And this is now the stent implantation, which was fully controlled by the robotic system, and you can see how precisely the positioning was in this case. And this was a 3.45 over 28 millimeters, which was followed by the POT, the proximal optimization technique. Of course, we had to rewire the LED. We did this controlled by the robotic system again, and you can see how easy this rewiring was in the LED. Finally, we had to finish with a kissing balloon, and of course a final POT, which brings up to the final iris, and you can see this nice expansion in this severe calcified ostial circ. Of course, you had this eccentric expansion. However, this what I think because of this severe napkin situation. However, the malposition, there was no malposition and an acceptable expansion. This is the final angio showing a very nice result in the caudal and in the areal projection. Well, finally, I want to conclude clarification very distally, as we want to go very distally. You have to position the guide wire very precisely, and by doing or by pulling back the wire, we could cross the most distal stent cell, just for being optimal with the then following kissing balloon technique. And of course, as we try to cross the very distal lesion or cell with the manual PCI, you can do this very precisely with the robotic system. And in my experience, it's somehow more precise than you can perform it with the manual PCI, because you have this very small and millimeter-wise movements, which is maybe a little bit more accurate than it is with the manual PCI.
Okay, thank you. Bruno, we have a lot of questions.
A lot of questions, and one for Helge maybe about, you know, when...
If you have a new device, balloon, be it OCT, be it whatever it is over the wire, you have, of course, to insert it. So you have to take out the wire, insert it, bring back the wire. But this, now we are talking about seconds. It's not like half a minute or a minute, which will be the whole procedure longer. It's really only seconds. Therefore, I think this is definitely not an issue which has to be discussed.
Okay, thank you very much. I think we can move to the last video, which is coming from Dr. Gratham from the Mid-America Heart Institute in Kansas City.
Kansas City. associate professor of medicine at the University of Missouri, Kansas City, and acting coronary chief to health and our world has never been more effective of procedures. Those pillars will remain fundamental to our mission, but what excites me even more is physician and quality, working various procedural population of cardiologists and the potential for resulting physicians or treated treatments to patients regardless of physical location. And then the CorePath vascular robotic technology has already been used to successfully demonstrate the feasibility of long-distance, multi-location remote procedures over existing and developmental 5G networks. The technology was used by Ryan Mader of Spectrum Health in Grand Rapids, Michigan, spanning distances of 200 and 3,000 miles between the operator and the system. Pictured here, Ryan is seated in a remote cockpit housed at AT&T headquarters in Waltham, Massachusetts. A remote robotic arm was placed in New York City and another one in San Francisco, and teams there assisted Ryan, who performed a series of simulated PCIs using 4G, 5G, and fiber optic broadband communication. Ryan could detect no difference in the performance of these procedures through those various, some commercial and some developmental pathways. And the world's first in human telerobotic PCI procedures were performed already in 2019 by Tejas Patel. Tejas was in Ahmedabad, India, operating from a temple on a patient 20 miles away at his hospital in Ahmedabad. Tejas published this work in Lancet last year. This work has demonstrated this future treatment paradigm is feasible and could be a reality within years, not decades. The hospitals who will be at the forefront of driving this transformation are the ones building robotic programs today. And we're now in the pre-submission phase with our FDA in the design of a trial of telerobotic PCI in the United States. Dr. Mader is the principal investigator, and Dr. Alexandra Lancey's group is serving as our clinical research organization. We look forward to the initiation of that trial in the very near future. Imagine you could gain access to PCI techniques that some of the most highly skilled operators are using. AI, artificial intelligence, of one of those technique package techniques. This is wire spin. So again, we collected information from several interventional cardiologists about how they spin a wire, how fast they spin, how hard they push, how hard they pull back, programmed that into the robot. So when you turn on this function, the wire will spin at a constant speed, like interventional cardiologists who are some of the world's leading experts do it. There are other specific techniques that have been automated as part of this technique package and are now commercially available. We're rolling it out to current customers. On the right-hand side of the screen is a look into the future. On the right-hand screen, what we've done is produce a 3D reconstruction of a coronary artery based upon two orthogonal views obtained with Siemens angiographic equipment. We're then able to map the pathway through that lesion. And then once that pathway is mapped, we can synchronize the tip of the wire to the pathway with feedback to the robotic. So as the wire is moving closer to the target, which is a little red dot there that a physician placed by touching a touch screen, we can get the wire to move toward that. And anytime it moves away, it pulls back, rotates, and gets back online. So this is entirely automated wire movement, which can improve efficiency and consistency of techniques in interventional cardiology. Today, you have multiple technologies in your lab, and each one's instrumental in doing the work that you provide. But imagine what you could achieve if they work together and even learn from each other to improve our ability to see what's going on, to make the best decisions about the course of treatment, and to deliver that treatment precisely and efficiently. Planned synchronization between imaging systems and robotic systems has the potential to improve case workflow, in-room efficiency, and a new level of intelligence will enable an integrated angio suite where imaging equipment and robotics work synchronously to deliver safe, more effective, and more consistent patient care. This combination will ultimately inform case strategy and allow us to focus even more on our patients. By leveraging learning algorithms delivered from large population data sets, the integrated system might deliver procedural treatment plans that further reduce variability We call this prescriptive analytics, a system of providing feedback to operators about how to proceed in a more efficient way. Think about how social media companies use algorithms that examine your online usage and target you for advertising. Well, instead of annoying ads popping up on your Facebook page, we might envision a great advice pop-up in response to a difficulty you might be having getting a balloon across a very tight lesion, wiring through a severely angulated side branch, or even crossing a chronic total occlusion. So thank you for your time and interest today. I'd like to close by saying these are very exciting, there are very exciting things to come in the field of robotics that will address